The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi everyone, I am Ana Romina Cruz and I will be lecturing your anatomy and histology of the pelvis and the perineum. Okay, so over the years, majority or a chunk of your examiners in the PLE are actually obstetricians and gynecologists. So this part of your anatomy lecture and your handout should be mastered. Okay, and a big chunk of your PLE questions in anatomy would be clinical. And that said, marami silang questions na tinatanong on OB or gyne OR. So you have to master this part of your anatomy lecture. So let's begin with the bones of your pelvis. Your pelvis is composed of 4 bones. First, you have your sacrum, then your coccyx, also called your tailbone, and 2 innominate bones. So your sacrum is made out of fused 5 sacral vertebra, while your coccyx is made out of 3 to 5 fused rudimentary vertebrae. Majority of your coccyx would actually be made out of 4. And then you have your 2 innominate bones. Each innominate bone would be composed of your ilium, your ischium, and your pubis. So the true and your false pelvis is divided at the pelvic brim, which is bound anteriorly by your symphysis pubis, and then laterally by your iliopectineal line, and posteriorly by your sacral promontory. Yung false pelvis nyo is the area above the pelvic brim, and it's also known as your greater pelvis or your pelvis minor. And the area below the pelvic brim is also called as your true pelvis, or the lesser pelvis, or your pelvis minor. So your pelvis is divided into 3, your inlet, your outlet, and your pelvic cavity. Your pelvic inlet is the anatomical limit between the true and the false pelvis above. So technically, it has the same boundaries as your pelvic brim. So that's your symphysis pubis, your iliopectineal line, and your sacral promontory. So this plane right here is your pelvic inlet. The pelvic outlet, on the other hand, is bound by your pubic arch, the ischial tuberosities laterally, and the tip of your coccyx posteriorly. And the space between your inlet and your outlet is called your pelvic cavity. And this area is where you will find your pelvic organs. So the pelvis varies from person to person, and the Caldwell Molloy made an anatomical classification of the pelvis based on the usual shapes. You have your gynecoid, your android, your anthropoid, and your platypuloid types of pelvis. And these are all determined by the greatest transverse diameter of the inlet and its division into your anterior and your posterior segments. The different pelvic types usually also have similarities in other components of your bony pelvis. So let's first discuss your pelvic inlet. Sa pelvic inlet natin, we have different conjugates that you can measure. You have your true conjugate. This is your true conjugate, which corresponds to the distance from the sacral promontory to the superior margin of your pubic symphysis. Your diagonal conjugate, which corresponds to the sacral promontory to the inferior margin of your pubis, and your obstetric conjugate. So among these 3, the most significant obstetrically would be your obstetric conjugate. Kaya siya obstetric conjugate, di ba? So kung maghuhula na lang din kayo kung ano most significant obstetrically, that's your obstetric conjugate. And it's because it's the shortest pelvic inlet diameter through which your fetal head must pass through during birth. However, this conjugate could not be assessed clinically. So what we do is we estimate this conjugate by indirectly subtracting 1.5 to 2 centimeters from your diagonal conjugate, because your diagonal conjugate is the only conjugate of your pelvic inlet which can be assessed clinically. And during your pelvic examination, so nung nag-internship kayo during OB, your pelvis is assessed through its three different planes. The diagonal conjugate, as I said a while ago, is assessed to measure the adequacy of your inlet. And it is said to be adequate if it measures 11.5 to 12 centimeters. So, kung adequate, kung pag nag-IE tayo at hindi mo naaabot yung sacral promontory, that's most likely an adequate inlet. Kasi usually ito naman is around 10 to 11 centimeters. So, for an adequate inlet, sometimes, unless you have big hands, you cannot expect na re-reach mo agad yung sacral promontory. So the midplane, on the other hand, would correspond to the space, again, in your pelvic cavity bounded by your inlet and your outlet. And since this is a huge space, you have several structures to assess here during your internal examination. In a clinically adequate pelvis for delivery, your bispinous diameter should measure at least 10 centimeters. The ischial spines are blunt. Your side walls are parallel or divergent. The sacrum is inclined posteriorly. The sacral notches are wide and the sacrum is hollow. Okay? Pero syempre, minsan, hindi yun laging nakikita sa lahat ng adequate midplane. But these are the things you should assess during your internal examination. On the other hand, your pelvic outlet, ang tinitignan natin would be your pubic arch, your coccyx, and your bituberous diameter. The bituberous diameter in an adequate pelvis would usually measure more than 8.5 centimeters, while the pubic arch usually measures 90 degrees or more in a woman for delivery. So, question. So, which of the following anatomic feature makes the male pelvis different from the female pelvis? Is it A, a broader sacrum, B, ischial tuberosities are further apart, C, sacrum is less curved, or D, a more rounded obturator of foramen? So in females, the sacrum, as we said earlier, is wider and is shorter. The ischial tuberosities are farther apart, at least 8.5 centimeters, and the sacrum is less curved, so making the delivery of your fetus easier. So the answer here is D. So your male pelvis has a more rounded obturator foramen. So this is a table showing the other differences between your male and your female pelvis. Para madali nyong maalala, isipin nyo na lang palagi, like, ano bang mas okay para makalabas agad yung baby sa pelvic cavity? So the inlet is better if it is oval as opposed to a heart-shaped male pelvis. It is bigger and the outlet is larger. The sacrum is shorter and less pronounced than your males. And the pubic arch is more right or obtuse than acute. And the ischial spines should be more everted or diverted. And your pelvis houses different organs. For both the males and your females, you would find your bladder, your ureter, the sigmoid colon, and the rectum. Nagbabago lang sila sa reproductive organs na nakikita sa loob ng pelvic cavity. So in the females, you just think of all the derivatives of your Mullerian duct. So that's your ovary, your upper vagina, your uterine tubes, as well as your uterus. And then for the males, you have your prostate, the urethra, the prostatic part of your urethra, the vas deferens, and your seminal vesicles. So your bony pelvis is also composed of notches and two sciatic foramens. These two foramens are separated by the ischial spine and are bound by the sacrotuberous and the sacrospinous ligaments. Sacrospinous and sacrotuberous ligaments. So sacrum to the spines, sacrums to the tuberosities. Your greater sciatic foramen would provide an exit from the pelvis into your gluteal region, and your lesser sciatic foramen would provide an entrance to the perineum part from the gluteal region. So there are 4 structures that pass through your lesser sciatic foramen, and 3 of which would also pass through your greater sciatic foramen and would enter your lesser sciatic foramen. These would be your pudendal nerve, your internal pudendal vessels, and the nerve to the obturator internus. So technically, there's only one structure that passes through your lesser sciatic foramen that does not exit your greater sciatic foramen, and that would be the tendon of your obturatus internus muscle. So mas marami ang dumadaan sa greater sciatic foramen. You have 9 structures all in all that exit the greater sciatic foramen. Yung tatlo na-mention na natin, ito yung mga pumapasok din sa lesser sciatic foramen. And the other three structures only exit your greater sciatic foramen. And this would be your piriformis, your superior and inferior gluteal vessels, the nerve to the quadratus femoris, the sciatic nerve, and the posterior cutaneous nerve of the thigh. And this is the summary table showing the structures that pass through your greater and the lesser sciatic foramen. The ones not in bold are the structures which pass through both. So to easily remember these structures, we have two mnemonics. And for your greater sciatic nerve, ang mnemonic natin would be snip-nip. Snip-nip for sciatic nerve, nerve to obturator internus, internal pudendal vessels, the pudendal nerve, the nerve to quadratus femoris, the inferior and superior gluteal vessels, the piriformis, and the posterior femoral cutaneous nerve. While for the lesser foramen, we have pinto. So huwag kayong malilito sa letter N ng snip-nip and ng pinto. Ang nauulit na letter N would be the nerve to the obturator internus. Okay, so ito yung nerve sa pinto. While the other N in snip-nip would be the nerve to the quadratus femoris. Okay, so next question. After vaginal delivery, a laceration was noted to include the rectal mucosa. So which of the following structures is least likely to be involved? So to answer this question, we must first know the structures in your pelvic floor. So the muscles in this area make up two diaphragms. You have your urogenital diaphragm and your pelvic diaphragm. Yung urogenital diaphragm is a strong muscular membrane composed of your sphincter urethra and your deep transverse perineal muscles, which is found in the anterior part of the perineum. And this diaphragm would actually occupy the area between the pubic symphysis and your ischial tuberosities. This diaphragm would fill in the urogenital hiatus, which is the gap under the pubic arch where the levator ani is complete. So as you can see here, this is your levator ani, and ito yung incomplete area. And this area is where you will find your urogenital diaphragm. So this diaphragm would support your urethra and would maintain the uterovesical junction. The inferior fascia of this diaphragm is actually called your perineal membrane. You also have your pelvic diaphragm, and your pelvic diaphragm is a very wide but thin muscular layer of tissue that forms the inferior border of the abdominal pelvic cavity. And this is composed by your coccygeus muscle right here and your levator ani muscle. Yung levator ani muscle natin is composed of three different muscles: your puborectalis, your pubococcygeus, and your iliococcygeus. So the urogenital diaphragm is inferior, meaning more external to the pelvic diaphragm. So this photo here is a view from under looking up. And if you remove the muscles of your urogenital diaphragm, ganito yung magiging itsura niya. Makikita mo yung pelvic diaphragm composed of your levator ani and your coccygeus muscles. Okay, and dapat nandito nakapatong dyan, more external to that would be your urogenital diaphragm. Okay? Your levator ani, as we said, is composed of your three muscles, and this is a sling-like group of muscles supporting the pelvic organs, which serves to maintain the pelvic viscera in position. Besides this, it also serves to resist the rise in intrapelvic pressure during straining and provides sphincter action on the anorectal junction and as a vaginal sphincter in females. Okay, so more inferior to your pelvic diaphragm is your perineum, and the perineum is bounded by the following anatomical borders. Anteriorly, you have your pubic symphysis, anterolaterally by your pubic rami and your ischial rami, laterally by your ischial tuberosities, posterolaterally by the sacrotuberous ligaments, but it's not seen here, and inferiorly by your sacrum and the coccyx. So an arbitrary line joining your ischial tuberosities divides the perineum into your anterior triangle, also called your urogenital triangle, and the posterior triangle termed your anal triangle. So obviously, yung urogenital triangle, this would house your urogenital organs, and you would find the root of your scrotum and the penis in males, and then your external genitalia in the females. The anal triangle, on the other hand, is where we will find the anal canal, the external and the internal anal sphincters, and your ischioanal fossae, and in both your males and your females. So the muscles found in the superficial perineal space, including your bulbospongiosus, also known as your bulbocavernosus, along with your external anal sphincter, the transverse perineal muscles, all converge into at a site midline called your perineal body. Ito yon. Okay? Pero as we said earlier, yung external anal sphincter is actually part of your anal triangle, while the others are part of your urogenital triangle. So ano ba nakikita natin sa perineal area? So we have different pouches bound by several fascias or membranes in the perineum. The first fascia is called your superficial perineal fascia, which is continuous to the superficial fascial layers of your anterior abdominal wall. So this superficial perineal fascia can be divisible into two different layers. You have your superficial fatty layer and your deep membranous layer, also called your colles fascia. So remember, di ba, sa abdominal cavity natin, we have your superficial layer, also called as your campers, your fatty campers, and your skinny scarpa. So yung scarpa's fascia in the anterior abdominal wall would be continuous to the colles fascia in the superficial perineal fascia. Okay? And the second perineal fascia is your deep or perineal membrane, which serves as the inferior fascia of your urogenital diaphragm. It is the inferior boundary of your deep perineal pouch and the superior boundary of your superficial perineal pouch. Okay, so going back to our question earlier, as you can see in this diagram, the ischiocavernosus comes from the ischial tuberosities and would insert toward the crura of the clitoris. And during episiotomy, whether that's median episiotomy or a right mediolateral episiotomy, hindi ito natatamaan. So the answer here would be your ischiocavernosus. So let's review the structures of your perineum na pwedeng matamaan during vaginal delivery. So fill in the blanks tayo. So here in this photo, you can see three striated muscles. And nabanggit natin kanina, yung isang muscle natin found in the perineum would be your bulbospongiosus, also known as your bulbocavernosus muscle. Medyo mas lumang term na yung bulbocavernosus, but it's actually the same as your bulbospongiosus. And then, kung naalala niyo yung diagram kanina, yung blue na muscle sa photo, so that's your transverse perineal muscle. So ano pa yung isa pang striated muscle natin dito in this area? Found in your anal triangle. That's your external anal sphincter. So you have two structures left. One is pointing into a medyo bigger space, and then the other one pointing to a lining. So remember, yung internal anal sphincter natin is not a striated muscle. So this is actually your internal anal sphincter. And the lining pointed to right here in this photo would be your rectal mucosa. So ito yung structures that you can cut during your episiotomy during vaginal delivery, especially if you undergo a fourth-degree laceration. So again, perineal spaces. Ulitin natin to since for me, ito yung sa mga pinaka-nakakalito ng PLE, pero lagi siyang lumalabas sa board. So, i-memorize nyo to. The perineal membrane right here is the red line here. Okay? So, ito yung perineal membrane nyo. And as we said, your perineal membrane is the superior boundary of your superficial perineal pouch. Nasa baba siya kasi mas external, superficial, di ba? And the inferior boundary of your deep perineal pouch. perineal membrane. And the space between the perineal membrane and the superficial perineal fascia is your superficial perineal space, while the space between the perineal membrane and the pelvic diaphragm is the deep perineal space. Okay? So, anong structures ang nakikita sa spaces na to? So, for your superficial perineal space, you have the following structures. Generally, same lang for both your males and your females, except that your greater vestibular glands are also found in females. But all the rest, halos same lang. You have the roots of the penis and clitoris, your perineal muscles, bulbus sponjosus, esophagonosus, the perineal body, and the perineal branch of your pudendal nerve. On the other hand, sa deep perineal space natin, it mostly contains your neurovascular structures, parts of your urethra, the bulbourethral glands, and a part of your vagina. Okay? So next question. The distal part of the umbilical artery is obliterated in the adult and continues forward as what structure? So in adults, the distal umbilical artery obliterates to become the medial umbilical ligament. The arterial supply of the pelvis and the perineum mainly comes from the abdominal aorta, where it gives off the branches of your ovarian arteries and your common iliac arteries. So let's discuss first your ovarian artery. So when the ovarian arteries branch off sa abdominal aorta, it crosses your external iliac artery. And then it passes through the suspensory ligament to reach the ovary. Okay, so ito yun, itong area na yun. Supplying it and the lateral 1/3 of your fallopian tubes. Several branches would also anastomose with the uterine arteries under the suspensory ligament to give arterial supply to the uterus. And since the ovarian arteries comes from the abdominal aorta, which is a very high pressure vessel, if you fail to ligate ovarian arteries in your infundibulopelvic ligaments, you may cause a lot of bleeding. So very important to in cases of hysterectomy. No, it's very important that you are able to ligate these vessels well during hysterectomy. So kapag during uterine artery ligation or embolization naman, on the other hand, the blood supply to your uterus is still spared because you have branches from your ovarian artery, also called as the uterine branch of your ovarian artery. And as the abdominal aorta continues to descend, it then bifurcates at the level of your fourth lumbar vertebrae to become the right and left common iliac artery. The common iliac arteries then continues down to your pelvis. Okay. Level 4, it continues down to your pelvis and end when it divides to your external and your internal iliac arteries at the level of your pelvic brim. Okay? So, must know itong dalawang to. Abdominal artery bifurcates sa level ng fourth lumbar vertebra to become the right and left common iliacs, while your common iliac would bifurcate at the level of the pelvic brim to become your external and internal iliac arteries. So your external iliac artery does not supply organs in your pelvis, but it would give off 3 different arteries. You have your inferior epigastric, your deep circumflex arteries, which would supply the anterior abdominal wall. This is important in obstetrics because these vessels are cut or can be cut during skin incision during your cesarean section, especially your inferior epigastric artery when you do a malar incision. So ito yung madalas nakakat ha kapag cesarean section, your inferior epigastric artery. The external iliac also immediately passes the inguinal ligament, which would then become your femoral artery. And your femoral artery would supply your lower extremities. Majority of the blood supply to the pelvis would come from your internal iliac artery, which branches into your anterior and your posterior divisions. So yung posterior divisions natin, we have the acronym PILS. Your P is in posterior, ILS. So PILS. Your posterior branches extend to the buttocks and your thighs through three different arteries. You have your iliolumbar, your iliolumbar, your lateral sacral, and your superior gluteal artery. Yeah, iliolumbar, lateral sacral, and superior gluteal artery. PILS. The anterior division would provide supply to the pelvic organs and the perineum and would include both parietal and visceral branches. The parietal branches are in bold here in this table. So let's discuss yung branches na internal iliac artery. The first branch would be your umbilical artery. So your umbilical artery, the proximal part would become your superior vesical artery, which would supply the upper portion of the bladder. And in males, it would also give off the artery to your vas deferens. The distal portion would obliterate to become your medial umbilical ligament. So ito yung sa question natin kanina. The obturator artery, next artery natin sa internal iliac, is a parietal branch supplying the medial compartment to the thigh or your adductor thigh muscles. And then you have your vaginal artery in females, which would correspond to the inferior vesical artery in males. Your uterine artery or the artery to the ductus deferens in males. We'll discuss the uterine artery further later. Then your medial rectal artery, which would supply your rectum and the anal canal. And the last two parietal arteries, which would be your internal pudendal artery, predominantly supplying your perineum and the muscles of your anal canal, and your inferior gluteal artery, supplying the gluteus maximus, your piriformis, and your quadratus femoris muscles. Okay, so yan ang ating internal iliac artery. And it supplies a majority of your pelvic organs. Okay, so let's track the uterine artery in detail as it's a major blood supply to most female pelvic reproductive organs. I added to your handout the whole track of your uterine artery because your board examiners love this artery. As in, for some reason, marami silang natatanong sa artery na to. So let's start from the internal iliacs. Pagkalabas nito sa internal iliacs, as it branches off from there, it would enter the base of your broad ligament to reach the upper part of your cervix. And at approximately 1.5 to 2 centimeters lateral to your cervix, this is the area where the uterine artery would cross over the ureters, or what we usually call as your water under the bridge. The water being the ureter and the bridge being the uterine arteries. So at this point, the ureter may be injured or ligated, especially during hysterectomy, when the uterine vessels are clamped or ligated. And once the uterine artery has reached the upper portion of the cervix, it divides to an ascending and a descending branch. The smaller descending cervicovaginal artery, again, descending cervicovaginal artery, would supply blood to the lower cervix and the upper part of your vagina, while the main ascending branch, your main ascending branch would extend to the lateral margin of your uterus, between the leaves of your broad ligament, just before it reaches your fallopian tube. Just before it reaches the fallopian tube, it would divide into 3 terminal branches. So first would be your fundal branch. Fundal, kasi it would supply the upper part of the uterus. Your tubal branch, because it would supply the medial 2/3 of your fallopian tubes. And your ovarian branch, supplying blood supply to your ovaries. So numerous branches would also penetrate the uterine body to form your arcuate arteries. From your arcuate arteries, doon magbabranch off yung radial branches. And it would traverse further inward into the endometrium to become the basal arteries or your spiral arteries. The basal arteries are also called your straight arteries, which would supply the basal layer of your endometrium, while the spiral arteries are your coiled arteries, which would supply the functionalis layer of your endometrium. This is the layer which would be shed off during menstruation. So kahit yung arteries natin sa loob ng uterus comes from your uterine artery. Your internal pudendal artery, which is also a branch of your internal iliac, would leave the pelvic cavity through your greater sciatic foramen. Then it would enter the perineum through the lesser sciatic foramen, then travel to the pudendal canal, also called your Alcock's canal. So in this path, it crosses together with the pudendal vessels. It then sends off several branches. First, it would send off a branch to the external anal sphincter. This is called your inferior rectal artery. Then you have your perineal branches, which would supply your ischiocavernosus, vulvocavernosus, transverse perineal muscles, and the skin of your perineum. So all the muscles in your perineal area. Then you have branches to the posterior labial or scrotal arteries. Then a branch to the bulb of the vestibule or penis for the corpus spongiosum, and then dorsal arteries to the clitoris or the penis, and deep arteries to the clitoris or the penis. So among your other iliac, internal iliac arteries, ito pa yung isa sa mga arteries natin na marami pang sinusupply sa pelvic cavity and the perineum. So lastly, also found in your pelvis would be two other arteries, which is your median sacral artery, which is an unimpaired small artery that arises in the bifurcation of your aorta. It then descends at the anterior part of the sacrum and ends at the coccygeal body to supply the posterior portion of your rectum. And the other artery also found in your pelvic cavity would be the superior rectal artery, here, which would run medially at the base of the broad ligament, and then it would also supply the rectum and the upper anal canal. Okay, so moving on to the venous drainage of your pelvis. The venous drainage of your pelvis generally follows your arterial supply, except that the left ovarian vein would first drain to the left renal vein, while the right ovarian vein would drain directly to the inferior vena cava. So question, the structure that serves as a hallmark in doing pudendal block anesthesia through a transvaginal approach is and this is C, your ischial spines. So the autonomic innervation of the pelvis comes from several plexuses and nerves. So the abdominal sympathetic trunk is continuous with the sympathetic trunk that innervates your pelvis and is composed of 4 to 5 segmentally arranged ganglia. The pelvic splanchnic nerves derived from your S2 to S4 gives parasympathetic innervation to the pelvic viscera. You also have autonomic innervation from the superior hypogastric plexus, which would then divide to your right and left hypogastric nerves just below your sacral promontory. And lastly, you have your inferior hypogastric plexus formed by the hypogastric nerves, splanchnic nerves, and sympathetic trunk, innervating majority of your pelvic organs. The vesical plexus innervates the bladder, the middle rectal, the rectum, and the uterovaginal plexus, as well as your proximal fallopian tubes, uterus, and upper vagina. It also has extensions to your clitoris and your vestibular bulbs. On the other hand, the motor and sensory innervation of your pelvis would come from your lumbosacral plexus. The lumbosacral plexus is formed by the anterior rami of your L4 to S4, and it lies on the posterior wall anterior to the piriformis muscle. Okay, the sacral plexus would provide motor and sensory nerves for the posterior thigh, majority of the lower leg, the foot, and parts of your pelvis. And from this plexus would come your sciatic nerve, which is the largest nerve in the body, composed of your posterior common peroneal and anterior tibial parts. You also have several branches coming from the posterior femoral cutaneous nerve, which is divided to the posterior and the anterior division. Specifically, the sciatic nerve innervates the posterior compartment of the thigh or your hamstrings. So your superior gluteal nerve would innervate your gluteus medius and minimus. Your inferior gluteal nerve would innervate, your gluteus maximus, and your perineal nerve would innervate the muscles of your urogenital triangle. And since your pudendal nerve gives off somatic innervation to the external sphincter and to the muscles and skin of your perineum, blockage to this nerve is an option in minor vaginal surgeries or cases of pudendal neuralgia. Kaya ito yung binablock natin dun sa question kanina. And the pudendal nerve gives off other terminal nerves that would innervate the perineum, specifically your inferior rectal, your dorsal nerve to the penis or clitoris, and your perineal nerve. Okay. So for us to block it, we first need to know its pathway. The pudendal nerve would leave the main pelvic cavity through your greater sciatic foramen, right here. It would then enter the gluteal region of the lower limb, would curl around the attachment of your sacrospinous ligament at the ischial spine, and then enter the perineum through the lesser sciatic foramen. Then it would run to the pudendal canal. So this canal is formed by the obturator internus fascia and would transmit the pudendal nerve and internal pudendal vessels. And this canal is also called your Alcock's canal. So during your pudendal nerve block, we aim to block the nerve as it enters the lesser sciatic foramen. In females, it may be done transvaginally by palpating for the ischial spines as seen in this photo. And once identified, the needle is gently introduced to puncture the vaginal mucosa and the sacrospinous ligament. The local anesthetic is then injected just posteriorly to the ischial spine at the attachment of the sacrospinous ligament. If we do a perineal approach, transperineal approach, especially in males, yung ischial spines natin are still palpated through the rectum. So in females, you may also palpate the ischial spines through the vagina. And hindi mo kailangan transvaginal approach. You can also do a transperineal approach in your females. The needle entry point is 1 inch posteromedial to the ischial tuberosity. And once punctured, it is then advanced until it reaches the ischial spines before injecting the local anesthetic to the sacrospinous ligament, medial and inferior to your ischial spines. So let's talk about the lymph node drainage of your pelvis. Your pelvic organs have several lymph node drainage. And the trick here, parang sa venous drainage lang, is to think of their arterial supply. So yun ang pinaka-importante na muna ma-memorize natin sa pelvis and sa perineum, yung arterial supply niya. Usually, kung ano yung arterial supply, yun na rin yung katumbas nilang lymph node drainage. So for example, your upper rectum is supplied by the superior rectal artery, and your superior rectal artery would come from the inferior mesenteric artery. So the lymph node drainage of your upper rectum is to the inferior mesenteric artery. And then remember, our ovarian artery would supply the ovaries, the tubes, and the uterus, the upper part of the uterus. So these parts would drain to the para-aortic lymph nodes, as opposed to the rest of your organs sa pelvis, which would drain through your iliacs. So for the lymphatic drainage of your perineum, on the other hand, it is generally through the inguinal lymph nodes. Pelvic organs, iliacs, para-aortic, inferior mesenteric. Perineum, inguinals, either superficial or deep, depending sa location ng structure. So except for your glands, your clitoris, and your labia minora, which drain to the deep inguinal lymph nodes, the rest of the structures in the perineum, including your abdominal wall, below the umbilicus, would drain to the superficial inguinal nodes before draining to your external iliacs. Okay, so let's move on to the female reproductive tract. Okay, so question. Early genital systems and two sexes are similar, and this is referred to as your indifferent stage and would last until what week of human development? And the answer here is until the 7th week. So you have indifferent gonads until the 7th week of development. And at this indifferent stage, internally, both the males and the females would have undifferentiated gonads, the Mullerian ducts and the mesonephric ducts. And externally, they would both have bilateral cloacal folds, your genital tubercle, the anal membranes, and urethral folds. And in the presence of a Y chromosome, the gonads would develop to become the testes. And this is due to the testis determining factor, or your TDF. TDF, which is found on the SRY gene on the short arm of your Y chromosome. So again, that's your testis determining factor on the SRY gene on the short arm of the Y chromosome. So after the 7th week, in the presence of a testes, testosterone and androstenedione would be secreted by the Leydig cells. And this would induce masculine differentiation of the mesonephric ducts and the external genitalia. On the other hand, the Sertoli cells would secrete your Mullerian inhibiting substance, also called as your AMH, or your anti-Mullerian hormone, which causes Mullerian duct regression in males. So by the 8th week of gestation, the gonads would begin to differ grossly. Yung sa males, your Mullerian ducts would regress due to the presence of your MIS or your AMH, while in females, your Wolffian ducts would regress due to the absence of testosterone. And maintain mo yung Mullerian duct kasi wala kang AMH or MIS. Your Wolffian ducts in males would then develop to form your epididymis, your vas deferens, and your ejaculatory ducts. And in males, you can have a remnant of your Mullerian ducts in adults, which is the vestigial appendix of your testes. In females, on the other hand, your Mullerian ducts would develop to form your uterine tubes, your uterus, and the upper 1/3 of your vagina. Yung remnant ng Wolffian duct in females would become your Gartner's ducts in females. So the external genitalia would develop through the presence of your sex hormones. In the male external genitalia, your phallus would enlarge and would elongate to form the penis, the corpora cavernosa, and the corpora spongosum, while your urogenital folds would form the ventral aspect of the penis and the spongy urethra. Yung labroscrotal swellings mo would grow towards each other in the males and would fuse to form the scrotum of your penis. And by 14 weeks of development, the male external genitalia would be complete. In the females, your external genitalia, on the other hand, would produce the clitoris if the growth of the phallus would cease. Your urogenital folds, if unfused, would be your labia minora, and the fused part of your urogenital folds would form the frenulum. Your labioscrotal swelling, yung unfused parts would become the labia majora, while the fused parts would form the anterior and the posterior labial commissures and the mons pubis above. The external genitalia in females is completed earlier than males at around 11 weeks age of gestation. And this is the summary table of the homologous structures in your males and your females. So let's now discuss in detail the female internal genitalia. The internal genitalia in females is composed of your ovaries and your Mullerian derivatives. So ovaries lang yung hindi Mullerian derivative. So again, yung Mullerian derivatives natin would be the uterine tubes, your uterus, and the vagina. The upper 1/3 of your vagina is from the Mullerian duct, while the lower 2/3 of your vagina would come from your urogenital sinus. The ovary is an oval structure measuring around 4 by 2 centimeters lying against the ovarian fossa, and it is bounded by your external iliac vessels above and the internal iliac vessels below. It serves to produce your female egg cells as well as your estrogen and progesterone. It is not covered by peritoneum, allowing expulsion of your ovum to the fimbriatic end of your uterine tubes. Okay? So it's not covered by peritoneum. Histologically, the ovarian surface is covered by a single layer of cuboidal cells termed your germinal epithelium. So this is the germinal epithelium. Immediately underneath the germinal epithelium is a very thin fibrous capsule called your tunica albuginea. Under your tunica albuginea is the outer cortex, where you will find your developing ovarian follicles and the stroma, while the inner medulla is the site of your blood vessels, nerves, and lymphatics. So here in the middle is your ovarian hilum, where the neurovascular structures pass to enter the ovarian parenchyma. Germinal epithelium, tunica albuginea, cortex, and then your inner medulla, hilum. So your ovaries have several attachments. The posterior portion of your broad ligament would form your mesovarium. Here you would find the arterial anastomotic branches of the ovarian and the uterine arteries, a plexus of veins, and the lateral end of the ovarian ligament. In the infundibulopelvic ligament, also called as your suspensory ligament of the ovary, this would form the superior and the lateral aspect of the broad ligament, and it would extend between the attachment of the mesovarium and the lateral walls of your pelvis. The ovarian ligament, on the other hand, also known as your utero-ovarian ligament, is sometimes called the round ligament of the ovary. It is a short, narrow fibrous band that would extend from the lower pole of the ovary to the uterus, and it is the remnant of the upper part of your gubernaculum in females. And to review, the ovarian arteries, which would come from the abdominal aorta at the level of L1, supplies the ovaries primarily, but it also is supported by the ovarian branch of your uterine arteries. So ito yung blood supply natin sa ovaries. While our venous drainage, as we said earlier, it is drained by the ovarian vein on both sides, but the left vein would drain to the left renal vein, while the right vein would drain directly to the inferior vena cava. Okay, ilang beses na yun naulit so dapat alam nyo na yun. And let's move on to your fallopian tubes. Yung fallopian tube natin, as we said earlier, it's a Mullerian duct derivative. It's about 4 inches long, and it is found at the upper border of the broad ligament. The fallopian tubes would connect to the peritoneal cavity in the region of the ovary with the cavity of the uterus and functions to do the following. So this is the site where we receive the ovum from the ovary during expulsion. It also is the site for fertilization, usually in the largest part of your fallopian tube. It also provides nourishment for the fertilized ovum through your PEG cells. It functions to transport the fertilized ovum to the cavity of the uterus and also serves as a passageway for the sperm cell to reach the ovum. So specifically, we have several parts in the fallopian tube. The infundibulum is the most distal part of your fallopian tube and has a fimbriated end. And this part is the part which receives the ova from the ovaries. The ampulla is the widest part with a diameter of around 5 to 8 millimeters. This is the site where fertilization occurs, and it is also the most common site for ectopic pregnancies. The isthmus is the narrowest portion of the fallopian tubes. The diameter is usually just about 2 to 3 millimeters, and it has the most developed musculature, and it is the preferred portion for female sterilization because this area is less vascular than the other areas of your fallopian tubes. And lastly, we have your intramural segment, also known as your interstitia, which pierces through the uterus, so this area. And from its name, it is the area surrounded by your myometrium, kaya siya intramural. So the medial two-thirds of your fallopian tubes is supplied by, as we said earlier, that's your uterine arteries, while the latter one-third is supplied by the branches of your ovarian artery. These are also drained by the corresponding veins. And again, saan galing ang uterine and ovarian arteries nyo? That would be your internal iliac and your abdominal aorta. So similarly, the lymphatic drainage would be the internal iliacs and your para-aortic nodes. So let's move on to your uterus. In a nulliparous woman, the uterus is about 8 centimeters by 5 centimeters wide and 2.5 centimeters thick, and weighs 40 to 50 grams. Each measurement is approximately 1.2 centimeters larger in your multiparous woman and weighs 20 to 30 grams heavier. So the dome-shaped top of your uterus is called your fundus, and the lower edge of this segment is an imaginary line drawn between the site of the entrance of your fallopian tubes. Below this area would be the body of your uterus, where you will find the uterine cavity. And this short area of constriction in your uterus right here, connecting the body of your uterus to the cervix, is called your uterine isthmus. Your uterine isthmus forms the lower uterine segment during pregnancy. The lowest part of your uterus is your cervix, which is the most distal portion, and it's a tube-like portion that pierces through your vagina. So anterior to the uterus, you would find the superior surface of the bladder, and the peritoneum in this area would reflect forward into the bladder dome to create your vesico-uterine pouch. Vesico-uterine pouch. On the other hand, sa posterior part natin, the entire posterior wall of your uterus is covered with, almost the entire posterior wall of the uterus is covered with serosa or visceral peritoneum. The lower portion of this peritoneum would form the anterior boundary of the recto-uterine pouch, or the posterior cul-de-sac, also known as your pouch of Douglas. So this area is the most dependent part of the entire peritoneal cavity when you are in the standing position. Posteriorly to this, you will find several coils of your ileum or the sigmoid colon behind your uterus. Laterally, it is bounded by your broad ligaments and your uterine vessels. So since the pouch of Douglas or the posterior cul-de-sac is the most dependent part of the peritoneal cavity, this area frequently becomes the site for accumulation of blood, such as in cases of ruptured ectopic pregnancies, or pus in cases of ruptured appendicitis or gonococcal peritonitis. Not only this, but besides your ovaries, this is also a common site for endometriotic implants. So anong importance nito clinically? So, although rarely done now, before, coldocentesis may be done to be able to diagnose the presence of abnormal fluid in the peritoneal cavity, such as blood or pus, in cases of suspected ectopic pregnancies or possible intra-abdominal infection. It is done by piercing through the posterior fornix of the vagina while the patient is in dorsal lithotomy position. Moreover, since it is also a common site for endometriotic implants, during the internal examination of areas with possible endometriosis during your IE and DRE, this is one of the areas we try to palpate for nodularities and tenderness besides your uterosacral ligaments. So also important during your pelvic examination or in a pelvic ultrasound is to assess the position of your uterus. The uterus is described to be either ante or retroflexed and ante or retroverted. Version of the uterus is based on the position of the long axis of the cervix with respect to the long axis of the vagina. Version yun. Again, version based on the long axis of the cervix to the long axis of your vagina. So if it is bent forward, it is anteverted. And if it's bent backward to this axis, it is retroverted. Flexion, on the other hand, is the relation of the long axis of the uterine body to the long axis of your cervix. So if there's forward bending of the uterus along the axis of the cervix, that's what we call your anteflexion. And if it's bent backwards based on the axis of your cervix, that's called your retroflexion. So again, pagversion, cervix to vaginal axis. Pagflexion, it's uterine body to cervical axis. So in the erect position and with a bladder empty, the uterus lies in an almost horizontal plane. Kaya ang usual position ng uterus is anteverted and anteflexed. And just a review, the uterus, just like the ovaries, is supplied and drained by the uterine and the ovarian artery and veins. And since the fundus has blood supply from the uterine branch of the ovarian artery, the corresponding lymphatic drainage is to the para-aortic lymph nodes, while the rest of the uterus would drain to your internal and external iliac nodes. So like your ovaries, the uterus has several attachments which would hold it in place, two of which, the uterosacral and the cardinal ligaments, would provide the most support to the uterus. But there are other supporting structures to your uterus, and one of which would be your broad ligament. Your broad ligaments are two wing-like structures formed by the peritoneum or your mesentery, which would extend from the lateral border of the uterus all the way to the pelvic side walls. Since it is formed by your peritoneum, they're not actually true ligaments. These broad ligaments would divide the pelvic cavity to your anterior and your posterior compartments. The peritoneum that overlies the fallopian tube is called your mesosalpinx, while that around the ovarian ligament is your mesovarium, and that attached to the uterus is your mesometrium. So our next ligament would be your round ligament. The round ligament of the uterus corresponds to the lower part of the gubernaculum. So naalala niyo po ba kung yung remnant ng upper part ng gubernaculum sa females? So yes, that's your ovarian or utero-ovarian ligament. So yung lower part is the round ligament of the uterus, and the upper remnant of your gubernaculum is the ovarian ligament. So your round ligament originates below and anterior to the origin of your fallopian tube. It would then extend laterally and downward into the inguinal canal, through which it passes to terminate in the upper portion of the labia majora. So the Samson artery, a branch of the uterine artery, would run within this ligament, and it is also its arterial blood supply. Okay, ang blood supply ng round ligament is your Samson artery. So round ligament, important dito, remnant ng gubernaculum, lower part ng gubernaculum, and that it terminates in the upper portion of your labia majora and yung Samson artery. Next is your cardinal ligament. As we said earlier, your cardinal ligament along with your uterosacral ligament would provide one of the strongest support to your uterus. And your cardinal ligament is also known as your transverse cervical or your McEnroe's ligament. It is the thick base of your broad ligament, and it is formed by the fibromuscular condensations of the pelvic fascia that attaches firmly to the cervix and the upper end of the vagina. And from its name, you have your pubocervical ligament. The pubocervical ligament passes through the cervix from the posterior surface of your pubis. And lastly, you have your uterosacrals. These ligaments originate from the superolateral portion of the cervix and the upper vagina, and would attach to the fascia anterior to your sacrum at the level of your S2 to S4. So they form the lateral boundaries of the pouch of Douglas, and along with your cardinal ligaments, provide the most support to the uterus and the vagina. So here in this photo, ito yung uterosacral ligament. You have your cardinals laterally, And then sa harap, you have your pubocervical ligament. Okay, so important to know that during gynecological surgeries, such as in hysterectomies, to be able to remove your uterus, we have to ligate it from all its attachments. And as such, other structures are vulnerable to injury at several points, especially your ureter. And these are the three most common sites for its injury. So first is immediately as it enters the pelvis at the area where the ureter lies just medial to the ovarian vessels within the suspensory or the infundibulopelvic ligaments, di ba? Remember, we have to ligate this ligament para ma-separate mo yung uterus to the ovaries. So this is the first common site for your ureteral injury. Next would be at the level of your uterine artery, where the ureter crosses inferior to the uterine vessels through the cardinal ligament at the level of the ischial spine. So remember, sabi rin natin kanina, it crosses anteriorly to the ureters at around 1.5 to 2 centimeters lateral to the cervix. And this area is near the cardinal ligaments. Kaya prone siya to injury because we have to ligate the cardinal ligaments. And very important to note that this is the most common area for your ureteral injury. And lastly, it is also vulnerable for injury at the area where your ureter enters the bladder. Because along its course, the ureter would turn medially, crossing the anterior portion of the vaginal dome, then enters the bladder. So this area is more susceptible to injuries in cases of dissection of the bladder. So I try to remember these three areas by thinking like, ano bang kailangan natin tanggalin na malapit sa ureter kapag natatanggal yung uterus? So these are your suspensory ligament and your cardinal ligament. Okay, so also for your uterus, last na to for your uterus, it is also important to know that it has several layers. The innermost layer of your uterus or the endometrium is lined by simple columnar epithelium and it contains long tubular glands. It has two concentric zones. First is your stratum basale, which corresponds to the lower one-third of your endometrium and is composed of very highly cellular lamina propria supplied by your basal or your straight arteries. And again, saan galing yung basal or straight arteries? It would come from the arcuate arteries of your uterine arteries. And then the other layer would be your stratum functionale, which is the superficial two-thirds of your endometrium composed of the luminal cells of your zona compacta and spongy stromal cells of the intermediate zona sponjosa. So these this area is supplied by the coiled or spiral arteries, and it is the layer responsive to your hormones. And since it's responsive to your hormones, it is also the layer that is sloughed off during menstruation. That's your strong stratum functionale. Inner to your endometrium, you have your myometrium, which is the thickest layer of your uterus, composed of smooth muscles, your venous plexuses, and lymphatics. It has inner longitudinal, middle oblique, and outer longitudinal muscles. And I remember this through the mnemonic LOL. So longitudinal, middle oblique, outer longitudinal. And lastly, you have your perimetrium or the outer layer of your uterus, which is continuous to your ligaments. So your cervix is the lowermost cylindrical or conical portion of the uterus, which consists predominantly fibrous tissue in contrast to the primarily muscular corpus of your uterus. Above the point where the vaginal wall is attached to the cervix, this is called your portio supravaginalis. And the portion protruding into the vagina, yung nakalabas sa vagina, is the portio vaginalis. In this area, it is supplied by your cervicovaginal arteries, which also comes from your uterine artery. Your cervicovaginal arteries would supply the cervix in the lateral cervical wall, specifically at the 3 and the 9 o'clock position. Histologically, the endocervix is lined by simple columnar epithelium with mucus-secreting glands, while the ectocervix has non-keratinizing squamous epithelium. The junction between the two, the endocervix and your ectocervix, is termed your squamocolumnar junction, since it's the junction between your simple columnar and your non-keratinizing squamous epithelium. So during pregnancy, yung endocervix natin would move out onto the ectocervix in a process which we termed eversion, which is why eventually in time, the transformation zone, which corresponds to the area between the old and the new squamocolumnar junction, increases. So let's move on to the vagina. The vagina is a muscular tube around 3 inches long that connects the uterus to the vulva, and it is derived from the combination of your Mullerian ducts above and the urogenital sinus below. So it serves as the female genital canal where menstrual blood flows and the passageway for birthing. So your vagina has 3 layers of support. The uppermost layer of support is formed by the ligaments surrounding the cervix and the vagina. So that would be your cardinal and your uterosacral ligaments. The middle third is formed by the vaginal attachment to the pelvic side walls, specifically the fascia overlying your levator ani muscles. And lastly, the lower third layer of support of your vagina is composed by the urogenital and your pelvic diaphragms. So just like your supports, the arterial blood supply to the vagina differs per third. The upper third of the vagina would come from the cervical vaginal branch of your the upper one third of the vagina would be supplied by the cervical vaginal branch of the uterine artery, while the middle third would come from the inferior vesical arteries, and the lower one third would come from the middle rectal and the internal pudendal arteries. Yung lymphatics natin, yung outer one third would drain to the inguinals, and it's innervated by the pudendal nerve, just like your perineum and the rest of your external genitalia. So isipin niyo na lang, since nasa labas yung part na yun ng vagina, technically, ang katumbas niya na areas would be the perineum. So, saan ba nagde-drain yung perineum natin? And ano yung nerve supplying the perineum? So, that would be your pudendal nerve and your inguinals. On the other hand, yung inner part of the vagina is actually part of your pelvic cavity. So, it would drain to your iliac nodes and is innervated by the same nerves that innervate the pelvic organs, which is your hypogastric plexus, your parasympathetic nerves, etc. Okay, so next question. As we move on to the last part of this lecture, a newborn male is found to have urethral openings along the ventral surface of the penis. The physician explains that the bilateral structures that should have fused in the midline failed to fuse completely, resulting to this defect. So which of the following structures in the female normally develop from the same structures that failed to fuse in this boy? Okay, so to answer this question, you have to know the homologous structures between the male and the female external genitalia. Obviously, the round ligament is not the answer because that's in your pelvic cavity. The clitoris is the sensory sex organ in females and is homologous to the crus of the penis, which comes from the genital tubercle. The labia majora is homologous to your male scrotum. And so the answer here is your labia minora, which is homologous to the ventral portion of the penis. So let's move on to your external genitalia. Your external genitalia, we collectively call this as your vulva, and it's composed by your mons pubis, your clitoris, the labia, the clitoris, the vestibule of the vagina, the hymen, vestibular bulb, and your greater and lesser vestibular glands. So this table summarizes the difference between your labia majora and your labia minora. So very important in this table is to know that both your labia minora and majora are actually lined by squamous epithelium, and only the outer part of your majora is keratinized. The labia majora is the fatty outer part of the vulva, where you would see your hair follicles, your sweat glands, and the sebaceous glands. On the other hand, the labia minora is the inner, more medial part, which has no hair follicles or sweat glands. And lastly, you have your vestibule. The vestibule is the area between the two labia minora, and it begins superiorly just below the clitoris and ends inferiorly at the posterior fourchette. So your vestibule has 6 openings. The vaginal introitus, the opening to the urethra, and the opening to your paired Skene's and Bartholin's glands. Skene's and Bartholin's glands. The hymen may also be visible in the vestibule, especially in those without any sexual contact. And it is composed of non-keratinized squamous epithelium. And in an adult female, we call the remnants of your hymen as your caruncle myrtiformis. The Skene's gland, right here, kaya siya tinatawag din na paraurethral glands, are found adjacent to the urethra, and these contain your tubulo-alveolar glands. The Bartholin's glands, on the other hand, at the lower part, found that the 4 and the 8 o'clock position would contain alveolar or compound acinar glands. And when the openings to the Bartholin's glands are blocked, this may cause your Bartholin's gland cyst, and when infected, it is called your Bartholin's abscess. Okay, so that ends your lecture in pelvis and the female reproductive tract. Again, gawin niyo yung best no to master this part of the anatomy lecture and handout. And congratulations on finishing another organ system.